morning. This day reminds us how far science and medicines have progressed. Cheers to the anniversary of the historical event today and wish everyone a very happy World Anesthesia Day. Good morning and warm welcome to Online Anesthesia. It is a postgraduate teaching program on Zoom platform sponsored by Akurla and hosted by A1 Logics and aired by Anesthesia TV. Today we are having two important topics in pediatric anesthesia. The first one is NORA, that is non-operating room anesthesia, and second one is anesthesia daycare surgery in pediatrics. For that, we have two eminent speakers in our online platform, Dr. DINESH KUMAR and GUNASEKARAN and RAKHEE, Dr. RAKHEE GOYAL. I welcome both to the online anesthesia platform. The first speaker, Dr. DINESH KUMAR, is a consultant pediatric anesthesiologist of GKNM Hospital of Coimbatore. He has completed hospital administration course, fellowship in pediatric anesthesiology. He has undergone observership in pediatric anesthesia in many countries like Switzerland, US, South Africa, and Belgium. He has delivered many guest lectures in various CME and conferences. He has got gold medal in MBBS and MD. He is the executive member of Indian Association of Pediatric Anesthesiologists, and he is the course director of IAPA fellowship in GKNM Hospital. He has published many research papers in pediatric anesthesia. Over to you, sir.
Thank you so much, sir. Thank you so much for the kind words. And at this onset, I would like to take this opportunity to wish everyone a happy World Anesthesia Day. Just a second. My screen is visible, sir?
No. Share your screen. Yes, sir, it's visible.
Okay. So my topic for today is NORA in pediatrics, which is non-operating room anesthesia. And I bring greetings from Kupsaminadu Memorial Hospital, Coimbatore. And coincidentally, we celebrate the 70th year of our hospital inauguration this year. So, NORA is nothing but administration of anesthesia, sedation, or monitored anesthesia care to patients undergoing painful or uncomfortable procedures at off-site locations. Most of our work, at least 25 to 35% of a regular institutional pediatric anesthesiology practice comprises of NORA. And NORA is more commonly required in pediatrics than in adults. And the most important thing here is we go out of a comfort zone, which is the operation theater, to provide NORA. So we have its own challenges. So most of the time when we go for a NORA, we see that the child is, in a very stressful situation. But what we don't know that this is how the child is looking at us. But what the child does not know is we are also equally scared about NORA, and we are equally paranoid about the procedure, mainly because it's out of a comfort zone. The staff, equipment, and help in emergency is very limited, or at least it takes a longer time than in the operation theater to reach us. And the risk and complications due to adverse events is potentially high. And the recognition time of the risk and adverse events is also takes a longer time than in the operation theaters. And these kids who come for NORA procedures tend to have multiple comorbidities, and they also have had their own share of previous anesthetics. So they're very paranoid when they come for the procedure the next time. As long as they're comfortable, they get more comfortable. Once they're paranoid, they get even more anxious for the subsequent anesthetics. And these children have a higher risk of anatomical and physiological variations which are undiagnosed, because most of them come for diagnostic procedures. Even the physician also does not know the diagnosis. So it has its own risks. And these days, kids have a very increased sensitivity to pain. So in previous generations, the kids who used to tolerate small procedures. Now we have the need to give anesthesia even for these smaller procedures where pain can be tolerated. And there is a lot of advent of new interventions with more enhancement in neuro, cardiac, minimally invasive procedures and all that. The need to give NORA is more. And there are also other challenges like communication issues, where in the NORA scenarios, the mobile phones don't work, the telephones don't work. Half the time we reach there first, we wait for the technician to come, we wait for the suction to work, we wait for the oxygen to be there, we wait for the scopes. So it's the communication issue is always a problem there. And there is increased incidence of airway complications. Always there can be an unavailability of medication and equipment. Frequent malfunctions because they are not very regularly used. Maybe that could also be another reason. And oftentimes we come across syndromic sick children. And another important challenge is there are undiagnosed myopathies and neuropathies, inadequate pre-preparation, and there is also radiation hazard to the personnel. So oftentimes we are like here sitting like a pilot in the war zone. And these are the people, which includes the surgeon, the technician, who take their own pool time to load things and do things. But here we are trying to balance the whole situation. So Dr. Ramesh, my mentor, he always says, do not get into trouble without knowing how to get out of the trouble. So I think that applies in NORA scenarios. But saying all the negative things, the positive thing is, this is a study done by Dr. Peter Davis. So a pediatric NORA by well-trained personnel is rarely accompanied by mortality and major morbidity. Presence of skilled anesthesiologists capable of airway rescue can avert catastrophic outcomes, and rate of morbidity and mortality decreases if ancillary personnel are trained. Ensure that the participating staff are adequately trained to assist in NORA. This is Dr. Joseph Tobias. He is the chief of pediatric anesthesia at Nationwide Children's Hospital, and I had the opportunity to intern with him for 1 month in the US. And this is his collaborative study with Pediatric Society in the US combined with Pediatric Anesthesia Society. So they formed a thing where critical elements for pediatric perioperative anesthesia environment was framed, and that says pre-procedural preparation, which includes a thorough clinical evaluation, ASIC grading, and always make sure that the high-risk pediatric patients consult anesthesiologists with a subspecialty certification or experience in pediatric anesthesia, which means who dedicate at least 25% of their clinical practice to neonates and children. And basic essential investigations, even if it is not there, please make sure that we get it done before we do the procedure, like CBC, serology, urea creatinine, mainly because oftentimes a contrast is used. And standard fasting guidelines sometimes may not even apply to endoscopy procedures. I'll be speaking in detail about it. Written informed consent from the parents and guardians. Optimization of the anesthetic plan and ventilation strategies according to the child's age and requirement. Arrangement of essential equipment in accordance to the procedure plan. Non-pharmacological interventions such as distraction. Oftentimes, we see that just giving a mobile phone to the child when the procedure is being done sorts the whole thing. Pre-medication only if warranted. Preparation of only the essential drugs. Don't have on the table unnecessary drugs, because unlike an OT, we don't know when we ask for flush, we might get some other drug which we might accidentally inject to the child. And always load the drug and keep only what is required for the weight of that specific child. And our first rule we all know is primum non nocere, which is first do no harm. And at least these basic things: suction, oxygen devices, airway, positioning, monitors and equipments of rescue like crash cart, defibrillator. I would also say ETCO2 here, if possible, to be kept ready. You'll be surprised to know that even though we might have kept all these ready, the suction might not be working when we need it really. Oxygen might not be delivering. The laryngoscope light might not be working. So make sure everything is properly checked and kept. We don't know when we'll need it. From the patient side, this is a plain drawing of a 10-year-old child with a severe headache. So imagine this child going into an MRI suite with more sound and all that. So I would rather say, if the child needs an anesthetic, please don't deny the child of anesthetic just because the situation is not conducive. So the most common NORA scenarios that we do is in the imaging suits, CT, MRI, and we do ultrasound guided biopsies. In the bronchoscopy suite, we have diagnostic bronchoscopy. We do foreign body removals. We do PEG, where the surgeon and the endoscopist combine together. Then we have the oncology and radiotherapy suites, where we do a lot of brachytherapy, chemo ports. We insert a lot of PICC lines. We also do a lot of cardiac and neuro interventional cath lab procedures. We do a lot of diagnostic procedures, a lot of daycare procedures. Dental itself is a topic where so many dental procedures are done. Ortho, burns, dressings, and we also come under NORA scenarios in dermatological and cosmetological procedures, where ear piercing, wart removal, mole, skin tag removals. So we'll take one by one in detail. We'll start with GI endoscopy. So GI endoscopy is either done for diagnostic or therapeutic procedures. And it's mostly done for upper GI, lower GI, or ERCP. So this is our endoscopy suite. This is a child who has undergone a PEG, where a surgeon is also involved. OGD scopies, it might range from 2 minutes to 20 minutes, but the problem is the procedure is highly stimulating. There is a thick, rich nervous system in the area where, though the procedure might be shorter, we need to keep the child in a deeper plane. And another important thing is we have to know our endoscopist. So if accordingly we give an anesthesia, accordingly we give the drugs, accordingly if we need, we intubate the child, accordingly if we can, we try to just sedate the child. And so everything depends on the endoscopist. So know your endoscopist. Most of the diagnostic GI endoscopies can be managed without intubation, whereas therapeutic might need intubation in pediatrics. Like variceal banding, foreign body removals, stent placements and removals, PICC placements, definitely we need a GA, sometimes even a caudal is given. And we must also know why the endoscopy is being done. And the fasting guidelines, which I was talking about, though the child might be fasted for 6 hours or 4 hours or 2 hours, we might still see some milk or solid food when we go inside. So always consider these children as full stomach. These kids might have an increased intra-abdominal pressure. The airway, always decide based on the child if a mask is enough or if you need a definitive airway, and be very cautious with the fasting guidelines. Induction, there is always a doubt if an IV or an inhalational is preferred. So you choose accordingly. So this is a scenario where we need 2 anesthetists, where one is putting the line and you can see the child comfortable, where another anesthetist is holding the mask with the CO4 of course. And another thing which we have to concentrate is always have a bite block. These GI scopies are very expensive. In case the child bites, then the endoscopist is going to take us also for a soup. And please make sure that you expose the abdomen and keep all the time, because in air, during endoscopy, there's a lot of air insufflation and the stomach might get big. This might compromise with the ventilation. There is also a lot of gastric distension. And once the procedure is done, inform your endoscopist to suction out the air before removing the endoscope. Why we emphasize this, we've come across a lot of situations where the child is malnourished, and when the endoscopist is overzealous, something like this happens. So this is a pneumoperitoneum where there was a perforation, and ultimately we were not able to ventilate the child. The lung was completely pushed up. We were not able to ventilate the child, and ultimately we were saved just putting a needle and deflating the stomach. Airway intubation will be needed for most therapeutic maneuvers. Diagnostic endoscopy, spontaneous breathing patient is acceptable, and always bear it in mind that it's a shared airway between the endoscopist and us. Anesthesia, propofol, fentanyl, or ketamine. We need something to antitussive, tube tolerance, and analgesia. So aim for a deep plane of anesthesia because of the rich nerve endings around the larynx and pharynx. So how do we judge the depth, the timing of endoscope insertion? Once we give propofol, and when there is an apnea, yes, that's a good time to go. You can ask your endoscopist to proceed. And another tip is when the pupils are central and looking perpendicularly up, that means the child is in a deeper plane, and again we can proceed. And after a propofol bolus, when the respiration is regular and slow, again that time the child is deep and we can go ahead with endoscopy. Other indications for intubation, though it might be a therapeutic procedure or a diagnostic procedure, when the child has a very poor apnea tolerance, something like a small child, distended abdomen, ascites, we straight away go for intubation. And when there is a higher risk of upper airway events like upper respiratory tract infection and asthma, again we go for intubation. We come across a lot of esophageal stricture dilatations where we have to anticipate residual food above the stricture. And post-operative, once the stricture is dilated, please watch for signs of esophageal perforation, which might present with severe pain, tachycardia, and sometimes later post-op, the child might have fever. And watch for pneumothorax, mediastinal air in X-ray. We've had a lot of situations. Lower GI or colonoscopy. The most important thing is these children are constipated. They have inflammatory bowel disease where a lot of steroids are given, or the child might be having severe diarrhea where the electrolytes may be abnormal. Malnutrition and failure to thrive. These children have their own set of complications. These colonoscopy procedures are longer procedures. Always watch for dehydration. There might be constriction of the colon, and the endoscopist might require us to give some hyoscine. These procedures are more painful. The technique that we can use is we can either keep the child in spontaneous or use an LMA if the procedure is long, or sometimes we can even use CO sedation and oxygen by Hudson mask and prongs. Most commonly used drugs, midazolam pre-medication only for extremely anxious child because we need to wake them up post the procedure. We try to avoid midazolam. Fentanyl, 1 mic, ketamine 1 mg, dexmed 1 mic, propofol 1 mg. CO of scavenging is adequate. And please give adequate IV fluids because they are dehydrated for all lower GI endoscopy procedures. So next is bronchoscopy. We do a lot of bronchoscopies. These are more challenging than the GI endoscopies. The airway is again shared. It's done in even smaller kids, less than 6 months, to rule out bronchomalacia and tracheomalacia. Diagnostic, we do a lot of anatomy assessment, and you need to keep the child spontaneously breathing to know the dynamic environment of the trachea, so that we know the collapsibility, we know the tracheal lumen. Once we paralyze, we lose the tone, and they're not able to diagnose what the actual problem is. And sometimes in therapeutic, we use bronchoscopy for lavage, removal of mucus plugs, and also foreign bodies. Airway, we can either have the child spontaneously breathing. Sometimes we can use intermittent mask technique. We can use a conduit LMA. Most often the normal LMA has an aperture which will block the bronchoscope from passing. So the most commonly used is Proseal. And Proseal is a good choice because we can also deflate the stomach. And very often we use the swivel connector. Through this, we can insert the bronchoscope. So the LMA and the size of the bronchoscope, most commonly we'll be using 1.52 or 2.5 for these kids. And in a 1.5 size LMA, a 3 mm bronchoscope can pass. In 2 and 2.5, 3.5 and 4 mm bronchoscopes can pass. And the next common procedure for bronchoscopy for the foreign bodies, removal of aspirated foreign body from the trachea and bronchus, GA with LMA, when we need to use a fiber optic bronchoscope removal, mostly a basket for removing a peanut or something like that. Rigid bronchoscopy, when there is a central foreign body, it's a very true emergency and very challenging. And we always, when you have to give excessive positive pressure, be very careful because you may cause pneumothorax. Jet ventilation may be useful, but can push the foreign body further. Shared airway and limited working space is concerned to the added difficulties of a remote location. Use of adequate anti-secretory medication definitely makes a lot of difference. And losing the airway followed by rapid desaturation and bradycardia is the most commonly encountered complication when you deal with a foreign body. So see, very often how I try to judge the child is when the child desaturates once and we ventilate the child and the saturation immediately picks up, it means it's a good child. We can let the saturation go even fall down further and give enough time for the endoscopist or the surgeon to remove the foreign body. But once it takes a longer time for you to ventilate and pick up the saturation, that is when you have to be worried. That means the lung is bad, the child has some other cardiac issues, or that's when it takes a longer time for the saturation to pick up. And always involve a senior or specialized pediatric anesthetist in such scenarios. So here you can see the swivel connector through which the bronchoscopy is passed. So how do we do it? We use a lot of anti-sialogogues, glycopyrrolate 5 to 10 mg per kg. We use dexamethasone default, fentanyl when needed. And when we use intermittent techniques, there's something called the sevoflurane bolus, where you keep 8%, take them deep, and once you cut it, give them back to the give the child back to the bronchoscopist for doing the procedure. And when you don't want to pollute the environment, please use propofol bolus. Jet ventilation helps, and post-op bronchodilator and adrenaline nebulization also helps. And like I said, for endoscopists, always know your bronchoscopist as well. It's like a marriage between the bronchoscopist and us, because you need to let the child desaturate when they're working, and the more time you give them, it'll be easier for them to pick up the foreign body and come out. So you need to have a better understanding with your bronchoscopist. Post-operative, always expect cough, bronchospasm, and glottic edema. Adrenaline nebulization, 1 in 1000 dilution, 2 to 4 ml for nebulization works well. So next, we'll move to radiological procedures. Again, remote monitoring. The most common procedures are CT and MRI. Common indications, they come for a global developmental delay. When a child has a first seizure episode, they may come to us. Neurotumors, hydrocephalus, spinal dysraphism, and non-neuro, they might come for ortho and GI procedures. Durations, mostly MRI brain takes around 20 minutes, abdominal again 20 minutes, spine takes around 30 to 40 minutes, and specific organs like cardiac MRI and all that takes around 40 to 60 minutes. Need for sedation in MRI, because we want the child to be absolutely immobile and we don't want any artifacts. Sometimes post-contrast, we may need them to hold their breath, and some kids are very claustrophobic, and that might be one specific reason we need to sedate them. So monitoring, problem specific for MRI is monitoring, which is remote monitoring. Metal objects, projectile missiles. We know the Mumbai incident where the oxygen cylinder was stuck, and in between the technician was there between the MRI machine and the oxygen cylinder. I think we lost him. Access, again, once the child is inside and we are outside, the access becomes an issue. Noise, the duration. And we all know that the MRI suit is very cold. To maintain the temperature of the machine, the environment is maintained very hypothermic. So please keep the child very warm, and always protect your personal equipments like phone, cards. All our ATM cards, once we take inside the MRI suit by mistake, it doesn't work once you come out. Keys, etc., which might again be projectile missiles. So this is our MRI suit, where you can see the baby completely draped warm. We just sedate it. We have the luxury of having a MRI compatible anesthesia machine inside. You can see the sevoflurane here. And another thing that we have adapted over time, where we can avoid all the hullabaloo, is a med bag. It's just a infant immobilizer, where once you take the air out, the med bag engulfs over the child. So just feed the child completely. Comfortable the child, once the child is comfortable and sleeping, you can just engulf in this med bag. And this is how the child is once in the med bag suit. This way we can avoid a lot of anesthetics. See, now more talks about neurotoxicity, repeated anesthetics. Med bag helps a lot, especially in children less than 10 kilos. CT with contrast, we have this technique of just using CO sedation, because they need to go back home, or they need to go back to the ward. Instead of giving IV, we just give a CO sedation, a bolus of CO, something like 8% for 2 minutes, and then cut the CO and come out. And CT is a very small procedure. The child has to go in and come out, hardly a minute or so. And CO sedation is more than good. And once the procedure is over, you just give a small stimulus, the child wakes up. And there is most of the time there is a request for apnea, where we've developed this technique over years, where you first hyperventilate the child and then you give a bolus dose of propofol. Then the child remains apneic for some time, where within that time the procedure is done. And contrast-induced allergy and anaphylaxis is always a concern. And contrast-induced renal failure, dehydration, pre-existing renal disease, juvenile diabetes, watch for all these. We must know that the effects of contrast could be either hypotension, sometimes hypertension, where the extravascular fluid moves intravascular, diuresis, and the effects of the contrast is directly proportional to the hypertonicity of the contrast. But these days, most of the contrasts that are available in the market are isotonic, so I think that shouldn't be a problem anymore. And definitely the risk of radiation is very significant than we think. Actually, it's cumulative, leads to malignancy, cataracts. Always try to use scans which do not use radiation, like MRI. Protect yourself and the child. Use aprons, lead goggles, thyroid shields. Please use dosimeters and check your annual dosages. See, what we don't know is exposure to radiation from natural sources just gives around 3 to 4 millisieverts. One chest X-ray is equal to 0.1 millisievert, but just one CT chest or a CT abdomen is 10 millisieverts, which is equal to 100 chest X-rays. There is a procedure called PET-CT, which is also done, that gives an exposure of around 25 millisieverts, which is equal to 250 chest X-rays. So we actually don't know what the radiation is doing to these kids or to us. So use it judiciously. The next most commonly done NORA procedures are interventional cardiology procedures, where occlusion devices for congenital heart disease, balloon dilatation, valvuloplasties for valvular lesions, electrophysiological studies like permanent pacemaker insertions, all these are done. For these kids, a thorough PAC has to be done. Please ask for history of cyanosis, shortness of breath, signs and symptoms of congestive cardiac failure, previous surgical or cardiac intervention which has already been done. Please check what anticoagulant therapy they're on and the other cardiac medications that they're taking. Sorry, just a second. Most of the times in a cardiac cath lab, we might need GA and sometimes only sedation. So always check for adequate perfusion of systemic and pulmonary circulation, filling pressures, heart rate, and coronary perfusion pressures definitely need to be maintained. Sometimes if needed, an invasive monitoring and blood gas analysis may be needed. At times when TEE needs to be done, always plan it as a GA. So this is our cardiac cath lab, where you can see a lot of equipments. Child, we are in one corner. You can see the long tubing, monitors, and the anesthesia machine here. We also do a lot of neuro-interventional radiology procedures, where we do them through endovascular approach, embolization of cerebral and dural AV malformations, coiling of cerebral aneurysm, thrombolysis, and balloon dilatation of vessels. It warrants adequate resuscitation, maintenance of cerebral perfusion pressures, and control of intracranial pressure. Most often, we do it under GA to tackle the hemodynamic instability and ensure normothermia. Complications, very often we come across hemorrhage, thromboembolic phenomena, coil occlusions, and cerebral vasospasms. So this is a biplane cath lab where again you can see the anesthesia machine here, the long tubings. The access to the child becomes difficult when they're doing the procedure. We have to do all yoga procedures to go and check the child in between. So other NORA scenarios, ortho cast applications, they come for repeated anesthetics, burns dressings, which need moderate sedation or TIVA. Dental anesthesia, dental procedures, that itself is a completely a single topic. And my favorite is using this atomizer, where without an IV line, we do a lot of dental procedures. We use dexmedetomidine, we use midazolam, we use ketamine, and it works very well. As long as once you master the technique, you get very comfortable with doing it without an IV line. Adequate supplementation of local anesthesia wherever possible. See, wherever you have a nerve, whenever possible, please do block it. In NORA scenario, drastically brings down the requirement of other drugs. We do a lot of ultrasound-guided biopsies, brachytherapy sedation, and diagnostic procedures don't give very high doses of any drug because you just need mild sedation. You don't have to give any analgesics. So this is renal biopsy, where you can see the child in prone position, but still we are comfortably sedate. And before piercing, the radiologist gives adequate sedation, adequate local infiltration, so that the child does not feel any pain at all. The renal biopsy, ultrasound-guided renal biopsy. So the sedation spectrum, we all know that minimal sedation, where the patient responds to verbal commands, moderate sedation, verbal commands only with addition of mild stimulus. So these two, please prefer them only for diagnostic procedures. Do not use my minimal sedation and moderate sedation for therapeutic procedures. Any therapeutic procedure, please keep them deep or straight away go for a GA. I usually prefer either a deep sedation or a GA. Avoid them for therapeutic. So two important pharmacokinetic concepts that we have to be aware is, one is dose stacking. Repeated administration before the peak effect of the previous dose reached causes a lot of side effects. And synergism, combination of drugs increase the risk of serious side effects. And the ideal sedation drug or the protocol, there's always a search for it. The ideal situation would be rapid induction and rapid emergence, more like switch on, switch off anesthesia. We need to provide, it needs to provide good anxiolysis, analgesia, and amnesia, sufficient control of movement to allow for ease of procedural completion, maintain effective spontaneous ventilation and airway control, complete cardiopulmonary stability throughout, and it should have minimal to no side effects. So please have adequate tools of the trade and be very comfortable in knowing those specific drugs, because without the right tools for the job, we always end up in situations like this. The most important implications, even though you might be called for a mild sedation or anything, always assume and prepare for deep sedation. The level of vigilance should always be maximal. Appropriate monitoring equipment, if possible, always include ETCO2 in your kit, and adequate trained personnel you should have. This is a study done by Charles Cote. We had the opportunity of meeting him in a conference. And this is a very famous study where around 95 adverse events in pediatric sedation were studied in detail, where 51 deaths and 9 permanent neurological injuries were there. So what this study says is mortality is very, very rare in pediatric sedation, whereas morbidity is not uncommon. So what they found was drug interactions, like combination of a lot of drugs, was the most important cause for those catastrophes. And the next most important cause was drug overdose, inadequate monitoring, inadequate CPR, inadequate anesthesia worker, pre-anesthesia worker, and premature discharge. So you need to know when you can discharge the child. Sometimes in non-hospital MRI suits, CT suits, where the anesthetist has to move on, a good freelancer might be having to move on to the next place. And a premature discharge from that place might cause a lot of problems. And this was very surprising. Inadequate personnel was the cause for around 10 catastrophes. So poor patient selection, drug overdose, lack of appreciation of drug interactions, pharmacokinetics and dynamics, use of multiple medications to sedate patient, which is definitely not necessary, lack of monitoring before, during, and most important, after the procedure, and inadequate CPR skills, failure to rescue were the causes of catastrophes. So conclusions, most complications are avoidable. Monitoring makes a huge difference. Adverse events involved multiple drugs. When we use one or two single drugs, we don't have much problems. Children 1 to 6 years are at the greatest risk. And always we need appropriate personnel skilled in airway management and resuscitation. So there are a few lessons to learn today, which we'll take home. Study the pharmacology of the drugs you plan on using. Become an expert on a few of these appropriate drugs. Start with small doses and titrate to the effect, because each child is different. They come in different shapes, different sizes, different pharmacokinetics, different elimination times, different metabolisms. So you start small doses and you see how they behave, and accordingly you titrate to the effect. And when combining the drugs, please decrease the dose of each component. For example, propofol 2 mg per kg, fentanyl 2 mg per kg, dexmed 2 mg per kg, midazolam 0.1 mg. All these together, if you give, you're going to land up in trouble. What we do is, when we use 2 drugs, we reduce the doses by half. When we use 3 drugs, we reduce the doses by 1/3. For example, 1 mg propofol, 1 mg ketamine, 1 mic dexmed. So that's how you go. You reduce the dose of each drug. And please learn that sufficient time should elapse before you redose. Suppose the child is moving, take them deeper with a little of inhalational than dosing the IV. Tailor your drugs to need. If you don't need an analgesic, for example, in a lot of dental procedures, just a local infiltration would do. You might have to intubate or sedate just for the sake of keeping the child immobile. That does not mean you have to give a narcotic, take them very deep, and things like that. So those are the things that will land us in trouble. You keep it simple, you'll be safe. So these are few tricks of the trade, where oxygen plus nitrous, a lot of dental procedures, nitrous sedation, yes. And this might be new to you. It's called Cineon, where we use sevoflurane, nitrous, and oxygen, where the plane is even more better. And this you might be aware of. Ketamine and midazolam, the hallucinating effects come down. Dexmed and ketamine. Dexmed might reduce the heart rate, whereas ketamine might increase the heart rate, and that will nullify each other. And ketofol, you must all be knowing, propofol can take care of the amnesia, and ketamine can take care of the little pain or the antitussive effect. And sometimes you can use ketofol combined with sevoflurane, and fentanyl plus propofol for more painful procedures. And for longer procedures, you can even use fentanyl and morphine, where you can give fentanyl and morphine combined, where fentanyl will take care of the immediate pain, whereas morphine takes at least half an hour to start acting. And that will take care of the pain after some time. And like the ideal drug that we were talking about, remifentanil, we think will be the closest to an ideal drug of NORA in future India. But the sad part is, though remifentanil was introduced in 1996, and though its patent was ended in 2017, even after 25 years, India still does not have remifentanil in the market. But once we have it, I think remifentanil will be a wonder drug in providing NORA, especially a very safe NORA drug, remifentanil, I can say. I've had the experience of using it abroad. So where we can improve, we can use a lot of topicals for children requiring venipunctures and lumbar punctures. When they are very small babies and they're fasted for a long time, we can even think about sucrose pacifiers, and always try to have a capnography in our periphery kit. And whenever possible, like I said, local infiltration for wounds with local anesthetics might solve most of the problems. And please don't deny any child of sedation for any painful procedure, like primum non nocere, which is first do no harm. Thank you so much. So here, what I would say is anesthesiologist is the pilot in NORA, and NORA is the takeoff and landing. Wish you all many more happy landings as far as NORA is concerned. And I take this opportunity to welcome you all to the 14th National Pediatric Anesthesia Conference in Coimbatore. Luckily, this time we're having it in Coimbatore, and it's going to be a fantastic India's first sustainable medical conclave. So please try registering. See you all there. I also take this opportunity to say that we run a 1-year pediatric anesthesia fellowship in GKNM Coimbatore. We have 2 seats per session, one in January and one in July, accredited by the Indian Association of Pediatric Anesthesia. Thank you so much. Thank you, sir. Thank you for the opportunity.
Thank you, Dinesh, for a clear presentation and loaded with a lot of information. So thank you so much for wonderful. There are a few questions in the chat box. We will take up the questions one by one. So which LMA you prefer, Dinesh? iGel or any?
Sir, ProSeal and iGel both are good enough, sir. So the most important thing in ProSeal and iGel is we have a port to deflate the stomach. Endoscopists, they tend to nicely sufflate the stomach, sir. So we have the opportunity to take out the air. Once we take out the air, we have the flexibility of the lung. Otherwise, the lung is fully pushed upwards and we're not able to ventilate. So once we deflate, we are in a better position to ventilate the child, actually, sir. So
ProSeal is the best option. Yeah. So the pedichloral syrup is traditionally used for a long time in pediatric anesthesia for sedation. So what is your experience? Still it is has any role in the pediatric anesthesia, pedichloral?
Pedichloral used to have a very good role, 50 to 100 mg per kg. But now the latest consensus is it is carcinogenic, they say, pedichloral. So a lot of places pedichloral is avoided, especially in the West. They don't use pedichloral anymore. So if we have no other option, if we are in a periphery center, because it has been used for a longer time, the carcinogenic effect and everything, now only it is coming up. So now only people are talking about it. So if we have no other option, I think we can go for pedichloral. So that's fine.
So the carcinogenic effect is due to continuous usage or a single dose?
So they say it is continuous usage, and most of these studies have only been done in animals, rat, mice, and all that. So nobody has tested it in babies, actually. So I think we have to use it judiciously, sir. There's nothing to prove in human beings the actual carcinogenicity.
Well, there are a lot of other alternatives are available. We can go for.
Yes, sir. Correct. Thank you.
Thank you. So other question is regarding the DEX kit experience.
Yes, sir. DEX kit we use regularly, sir. Where Dexmed keeps the child calm. The heart rate is when the heart rate is coming down, ketamine actually increases the heart rate, and it matches for each other. So it's very comfortable to use DEX kit. And DEX kit, another most important thing is we combine DEX intranasal, like I showed you, no, sir, the atomizer. We can just use a normal 2 ml syringe or an insulin syringe. We can connect the atomizer to the tip, and if possible, after a mild CO induction, if you can just spray, the absorption is better, sir, than when the child is awake. When the child is awake, if we try to, they might move, they may try to spit it out, they may try to sneeze it out. So make them a little comfortable with CO induction, and then you push Dexmed and ketamine. Dex we can go up to 2 to 3 mg per kg. Ketamine again 2 mg per kg we can intranasal.
But how will you calculate the dose per atomizer?
So we calculate the dose. We take the drug in the 2 ml syringe, sir, and
so
through the atomizer,
total dose in the syringe.
The total dose is just pushed into the nose, actually.
That's fine. So the next question is regarding that only. That is intranasal midazolam for NORA.
Midazolam, actually, what it does is it's very stingy to the nose than Dexmed and ketamine. Midazolam is tolerated less by children. It gives a very burning sensation in the nose. compared to dexmed and ketamine. So we try to avoid midazolam, but if there's nothing else available, if only midazolam is available, just see who induce them and push ketamine, and it's going to be fine. But another important thing is dexmed and ketamine works for just like 15-20 minutes. Whereas midazolam, they say the hangover effect of midazolam in children lasts for a longer time. We might think it's a short-acting drug, but the metabolism, the elimination, everything is delayed. They say the same thing for fentanyl also. The hangover, the analgesic effect lasts in fentanyl lasts for a shorter time, whereas the respiratory depression effect of fentanyl lasts for a few hours.
So is the metabolism of intranasal midazolam is different from IV midazolam?
No, sir. IV and intranasal is the same. The density of the venous plexus in the intranasal area is as good as IV absorption. So your IV absorption and intranasal absorption is very much comparable.
So the next interesting question, does the vaporizer output vary inside the magnetic field of MRI?
Oh, that's a good question. So I have no experience.
We have to go and read.
But I think that's a good thought, actually.
This is from KUMAR. We will refer and come to you, Muthu. So the last question is, do you have you experienced any adverse events in the MRI suite? If you don't mind, you can share with us.
So projectile missiles we've had, sir. Projectile missiles we've had coins. And the worst part is if they have to demagnetize the MRI machine, for them to again magnetize the MRI machine takes a lot of funds. It's very expensive to again magnetize the whole machine. So that is one thing. Another thing, yes, we've had our share of complications like desaturations. We've had to go into this thing and intubate the child. We've had arrests. We've had bradycardia. We've had our share of because we do a lot of volumes MRIs. We've had our share of complications. And in fact, another thing I wanted to bring to your notice, MRI and CT for lymphomas. Yes, that is one interesting complication I want to share actually. There was one situation where we just sedated this child. And once we sedated, the child lost the tone and all the lymphoma started falling on the trachea. We were not able to ventilate the child. We intubated the child, still we were not able to ventilate the child. And then we found out the lymphomas were compressing the individual right and left bronchi. Then we had to turn the child to prone, left, lateral. And in one position, we were able to ventilate the child. And then we reversed the child. Once the child got back the tone of the musculature, they were okay.
Okay. This is last question from me. You have mentioned that is morphine with fentanyl, but in NORA and daycare surgery, we prefer only the short-acting narcotics. Why in morphine in this NORA?
So there are a few longer procedures in NORA that we do. So, for example, the cath lab procedures. For example, there are a few bronchoscopy procedures, stenting. All these things takes a longer time, sir. Where we might keep the child intubated for some more time and then extubate. There we use fentanyl and morphine combined actually.
Then you will observe in the post-operative ward.
Yes, sir, observe in the post-operative ward.
Then it's okay. Thank you very much, sir. Mr. Prasad, sir, any other questions?
No, sir. Nice presentation, sir.
Second topic. Thank you, Dr.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thanks.
Thank you.
So I invite the second speaker, Dr. RAKHEE GOYAL, to our online anesthesia platform. She is currently working as Director of Anesthesia in Rainbow Children Hospital, Rosewalk by Rainbow Hospital, New Delhi. She has received Chief of Army Staff Commendation Award Medal, and she is the Founder Secretary of IAPA Delhi Chapter. Her area of interest is ultrasound guidance, supraglottic airways, one-lung ventilation, and bronchoscopy. Over to you, madam. Shilpa.
Good morning, everyone. Thank you, Professor Edward Johnson and his team for inviting me to this pediatric anesthesia series. I'm indeed delighted to be a part of it. And today, as you know, we are discussing two very special topics, which are simple, yet they can get very tricky and possibly unsafe if we don't understand them well. So we are here to discuss NORA and pediatric daycare surgeries. Some of the aspects of these two topics are common, and yet they are very different. So in this particular second half, I'm going to talk about anesthesia for pediatric daycare surgeries. I come from Rainbow Children's Hospital, New Delhi, and I bring greetings from my institution. So coming to the basic concept of what is daycare, whether it's pediatric or it's adult, we must understand what actually daycare surgery means. I guess most of you know that the common connotation of daycare is same-day admission and same-day discharge. Now, this concept of the same day is interpreted a little differently in different parts of the world and within our country in different kind of institutes. So like in the US, 65% of their surgical load is daycare. And they call it daycare if the admission is less than 23 hours. So they are called 23-hour stay. Basically, it's not 24 hours. And this huge percentage of daycare, besides other things, is because of a lot of pressure from the insurance companies to reduce the costs of, say, a particular surgery. So that's one very big reason for daycare surgeries to be encouraged and, as a result, more prevalent in the US. Now, when it comes to UK, right now they claim that it is around 50% of their surgical load is daycare, and they target their daycare to be 75%. Now, it seems pretty ambitious, but why not? Through this lecture in the next 15-20 minutes, we'll actually realize that there's so many advantages of daycare, and there are so many ways to make it safer, that this 75% could actually be achievable. These figures are, of course, for adults, mainly for adults. So when it comes to children, I wouldn't dare to claim such percentage, I must admit. Now, in these Western countries, whether it's 23-hour stay or lesser stay or whatever be the reason of the stay, the whole aim is that the care to the patient should meet the same standards as it would have been an inpatient. So, which means the daycare should be equal to, if not better, than the regular patients who stay overnight. And obviously, that goes without saying that no corners to be cut. The care should be of utmost standards. Now, so this was in the Western world. I've just given examples of two major countries that we often talk about and compare when we have to talk about countries other than our own. So when it comes to our own country, how is it different? So one, we don't really have a clear data, a clear percentage of what and how and what kind of daycare we have, because our healthcare is pretty diversified. There are government institutions, there are some semi-government, they're private, they're corporate, they're nursing homes. So we don't have one policy as of now, but that's okay. So mostly in the government institutions, the patients stay overnight. But then the daycare concept has come in, and I think it's progressing very fast. Now, in private and corporate, yes, because of the cost, there's such alarming cost that the patients themselves want an early discharge. Whereas the insurance patients, those who are covered by insurance company, what we have seen that a 24-hour stay is mostly with all insurance companies is mandatory. So that's counter our concept of daycare. So as I said, it's a very mixed and diversified kind of healthcare practice. So there it is. Now, duration of stay, as I said, insurance companies, they want more than 24 hours. But when otherwise, a non-insured patient comes, like in my hospital, the daycare means 6 hours stay. Anything more than 6 hours, probably the patient would be charged for the overnight costs. So the timing is set in such a way that the patient from admission to discharge does not cross 6 hours, unless, of course, there is some indication, and then there is a financial implication, of course. Now, in other countries, there's a follow-up by hospital staff once the patient goes home. But in our country, I'm really not sure how much is the follow-up. We'll talk about it eventually. And what is the backup healthcare facility near the patient's home? So these two are very important things, and we will talk about it as we go on. Now, obviously, it's very obvious that there are a lot of advantages of daycare surgeries. Now, when we talk about pediatric daycare, we know that if it's a daycare, we don't have to really depend on the availability of hospital beds. That could be really challenging in some of our government hospitals, even in some of the busy private hospitals. So if there is no bed, there is no worry. It's a daycare, patient comes, gets operated, and goes home. Really doesn't need an overnight bed. You can schedule surgeries with more flexibility. There is, since the child is not staying in the hospital acquired infections are possibly going to be less. The surgical waiting list gets shortened because the patients are not admitted, they're not due for their follow-ups in the wards, the discharges, and the whole process, as we know. So basically, the waiting in the list can be shortened if we increase the number of daycares. And when the hospital stay is shortened, the overall costs naturally would be less. I mean, it's phenomenal. The cost reduction is phenomenal in daycare versus in patients who are going to stay a day extra or more. So any institute can have a higher volume of patients and therefore higher efficiency. With the same infrastructure, with the same manpower, you could have more. Now, when it comes to children, I think when the child goes home after a procedure, he or she feels much better recovering in a familiar environment. That's home. You know, you have your own room, you have your own bed, your own toys, and maybe your own TV shows, you know, Peppa Pig and Frozen and whatnot. So if I were a kid, even as an adult, I would definitely like to come back to my own room in my house and recover there, rather than spend hours in a drab hospital bed with strange people in strange clothes around me. So with children, definitely the home environment is more comfortable and comforting, I would say. And overall, if we see in a country like ours, where there is so much of a dearth of healthcare facility, if we see overall, then if we encourage daycare, we will save a lot of funds, the national funds, which could help in the economic growth of the nation. Ultimately, that is. Now, obviously, if it was so good, every surgery would have been daycare. So there is a downside to daycare surgeries in children, because especially in children, the incidence of unplanned readmissions would definitely be high. There could be surgical complications, there could be anesthesia complications, the child may simply have emergence which is not settling. So even minor reasons would be a major reason for a readmission when it comes to especially smaller children. Now, if I'm operating on a child, I want to send him home the same day, the whole team would need higher expertise level. You got to give absolutely optimal of everything. Anything less or more would not ready the patient, the child, for discharge from the hospital so early. Another aspect is the PSC, the pre-anesthetic checkup. When we think that it's just a daycare, it's likely, just likely, and possibly there are chances of a slight overlook. Negligence is a very harsh term. I think a few things may be overlooked because it's not a major case. So that part we should keep in mind. A small thing like a loose tooth, probably NPO. Even the parents may take that procedure a little lightly because they think it's just coming in the morning and going after a couple of hours. So it's no big deal. So the instructions you've given about the NPO, the fasting, it may include other things as well. So that possibly may be taken lightly by the parents, the staff, you yourself. So that part we should remember. I think that's very important. And there is, as we say, there is no short GA and no short case. So we should really remember that. Another point, I think it's most important is to understand that daycare, children for daycare will be accompanied by parents who would have higher anxiety levels because they haven't got time. They've not been admitted a day prior. They're probably admitted 15 minutes prior to the procedure. So they're not mentally prepared. They've not settled in the hospital. So they'll be very, very anxious. And so would be the child, So as anesthetists, we'll have to deal with more anxiety. We should know that. So in 2016, the Royal Medical College in the UK came up with these advisory called Choosing Wisely pertaining to daycare surgeries. This advisory for all the clinicians and the caregivers. And I thought it's very apt, because the whole crux of giving a safe care to children on a daycare basis is to choose wisely. Now, what to choose? Both the patient, you have to choose the patients wisely and the procedures wisely, depending on your infrastructure, your staffing, the kind of facility you have on that day. So, commonly, we would prefer procedures that are going to be on the peripheries and not involving body cavities. Like I wouldn't prefer a daycare when it comes to a laparotomy or a thoracotomy. But if it's something on, one of the fingers, one of the toes, or a lump, or maybe an IND on one of the peripheries, it could possibly be yes. Duration of the procedure. Obviously, we will not like to go in for a procedure which is, say, more than 2 hours and then try to send the child home. No. Daycares are for short duration procedure. Now, 2 hours is not a magic figure. You have to take all things into consideration and then decide whether that duration is short or not so long. Now, we must see that what is the anticipated pain post-procedure. For example, if it's an IND, the child would come in pain, but after the IND, the pain would become better. It will be less than before, and oral analgesics will probably be enough. So that is fine for daycare. But in a surgery where there is considerable pain, like say an osteotomy, which is very painful, even if it's a short procedure, we won't want to send the child home the same day. So post-op pain, the anticipated post-op pain, that part should be kept in mind very seriously. Minimal physiological disturbances. Obviously, if there's a huge fluid shift, if there is blood loss, considerable blood loss in the surgery, so we wouldn't want to send the child home. Ability to take orally. Now, that's very important. You can't send a child who is not able to drink or eat anything. They can't be on IV fluids at home. So we must ensure that the anesthesia and surgery, whatever they've undergone, post that they are able to drink water, drink fluids, and able to take orally. Only then we should choose them for daycare surgeries. Now, when it comes to very small children, we must see whether they were full term or preterm. Now, premenstrual age, post-menstrual age of 44 weeks, which means, say, the baby was born at 38 and now it's 6 weeks. So that's okay for a small procedure. Or an ex-preemie who is now more than 60 weeks, like was born, say, 30 weeks, and now 30 more weeks have gone by. So a total of 60 weeks. So these two scenarios, so they have to be more than this to be probably qualified for a daycare. The second aspect is where are you doing it? Now, these preemies, neonates, or smaller infants should be done as daycare only in tertiary units. Now, if it's not a tertiary unit, then you really have to see that these 44 and 60 weeks are not enough. In other units which are not tertiary for pediatric, the age should be definitely more. And it goes without saying that history of OSA is a no-no for daycare surgeries. If the child has a history of OSA, we would not prefer daycare for obvious reasons. Let's come and see the common daycare procedures. So I'm sure you all are familiar with the non-surgical procedures. Now these are very, very common. GI endoscopies, radiological procedures like CT scan, MRI, cardiac cath, radiotherapy, some onco procedures where they just inject some drug intrathecally or take a bone marrow sample. There could be some ortho procedures like just a cast application or some injections into the joints, or some renal thing where they do ESWL for the stones, or it could be a dermatology procedure like laser treatment for some lesions. So these are pretty common procedures where a child would need sedation, probably moderate to deep, but then maybe really fit for a daycare basis. When it comes to actual surgical procedures, we should have these things in mind. I have not listed the name of the surgeries because there are too many factors that determine. If it's, say, I'll just give you an example. If it's a herniatomy in a child, is it unilateral? Is it bilateral? Is it laparoscopic? Is it open? How old is the child? Who is doing it? What is the duration of the surgery? Was it planned laparoscopically, but they opened it, so it really is not minimally invasive? Is there any chance of urinary retention that requires catheterization? So most things can be different. So that's the reason I've not named the surgery. So these are the factors, surgical factors, that you need to know when accepting a child for daycare. The other factors, surgical factors, being if there's a risk of post-op bleed, or you're putting a drain, or a risk of, say, there's a tibial fracture, there's a risk of compartment syndrome, risk of DVT, a need for IV fluids or IV antibiotics, then, so these are not the cases where you would consider daycare. Now, okay, so surgery, you've decided on the surgery, or maybe the surgeon has decided that we'll go in for daycare. So when it comes to PSC, what do we do? So these short procedures usually do not come physically for a PSC. So there are two ways of going about it. Either you do a tele-PSC or they self-report. So depending on the system that you have, if you have a system of a physical PSC, that's well and good. They could all be, in some of the Western countries, there's screening by the primary care providers. And you could take help by the internet or the intranet. So a PSC can be done. Basically, a PSC can be done and should be done. And you should realize that it should be cleared well, because there are implications of cancellations, and that could be huge. I think most PSC instructions should be given, particularly in these times, as a PDF. We have, like for children, we have a complete, detailed PDF, which has all the instructions, both anesthesia and surgery, in one document. And we give that document, we have the hard copy and the soft copy. So depending on the patient's choice, we give it to them. Even if the procedure is short, it's daycare, I think the instructions, as I said, the care has to be the same. So the instructions also have to be followed to the T. Now, we must take the contact number of parents, especially in daycare, because post-op follow-up is extremely important, and someone from the team, be it a nurse or a technician or as an anesthetist, should call up and follow up the patient after discharge. So we must have the contact number of the parents. Now, a few questions that come to our mind is, if it's a very short surgery, do you need any investigations preoperatively? Now, like in my institution, we do not ask for investigation. Suppose it's small IND or say toenail repair or some endoscopy. If the patient has already got the investigations done, well and good. Otherwise, we see physically whether there's pallor or in the history there is something, or physically if there is something, only then we ask for investigations. Otherwise, we don't. But there is no harm in getting your standard investigations done as per your hospital protocol or departmental protocol. Another question which is very tricky is a child with URTI. Say it's hernia and there is a runny nose. Would you accept the child for a daycare surgery? It's a yes and a no, both. So I'll leave that to your department, because that's a call. That's a collective call between your department and the surgical department, and you should take it together. Of course, along with the parents of the child. No, pre-op preparation is same as you would do for a non-daycare patient. So I would not go into details. I would more be interested in the pre-medication. Now, I think it's best not to give any pre-medication, because mostly you'll give orally or nasally, and that could linger. Even if I give short-acting drugs, they're likely to linger on for some time. So routinely, I would not like to give. I would rather use alternatives like distraction or inhalational induction with parental presence. That's what we routinely do at our institutes. So I would not really depend on drugs. But yes, if required, we could go ahead. But remember that they should be all very short-acting. Otherwise, discharge on the same day could be challenging. Now, induction and maintenance also. These are the things that came to my mind. Now, obviously, you will induce with short-acting drugs. You will go low on opioids. Propofol is the induction agent, which is short-acting. Opioids, you can probably give a short-acting fentanyl, but it's best avoided, I think. When it comes to airway devices, you can tube the child, but I would prefer a supraglottic device or simply a TIVA. Now, for most procedures can be done under TIVA. So lesser handling of the airway, lesser complications. But yes, if an airway device is indicated, we should go ahead with it. Now, I'm also worried about the post-op nausea vomiting. So I would avoid nitrous oxide and probably opioids as well. So you can take a call on that, but we should certainly avoid post-op nausea vomiting if we are planning to send the child home the same day. Fluids also, we should give enough so that immediate post-op, the IV fluids are not required, and we give enough time for the child to settle in and start taking orally. Prevention of emergence delirium. I think this is the most important factor that we should keep in mind, because these days when we use sevoflurane all the time, there is a problem with emergence, and that could really delay the admission. So we should take care of it and not send the child if there is emergence present. When it comes to analgesia, now if we are cutting down on opioids, what do we give? It's either NSAIDs, paracetamol, depends on the age of the child, whatever is safe, or a combination. And some regional blocks can be given. Now, local infiltration analgesia is the safest and non-controversial. But when it comes to peripheral nerve blocks or a simple caudal, I think that's a call you should take. Do you really want to give that? I would not prefer a central block. I would prefer maybe a USG guided peripheral nerve block. Why USG guided? Because then I'll need to give a very, very small amount of drug in a very specific region, which would probably not cause any urinary retention, any toxicity, drug toxicity. So it would add a lot of safety and it would give good analgesia. So overall, if I have to give a regional block, besides local infiltration analgesia, I would prefer a USG guided peripheral nerve block, which is very specific to the procedures. Otherwise, I'll rely on IV paracetamol and IV NSAIDs unless contraindicated. Extubation should always be smooth, whether it's deep or awake is the same when it comes to daycare or otherwise, but we want to send the child home, so we should keep time as on our mind. Yes. Now, post-anesthesia care unit is the most important place where you have to decide whether this child is ultimately fit. Even if the child is scheduled for daycare surgery, before you send, you have to take a call whether the child is fit to go home or not. So pain, PONV, excessive somnolence, these are important things. Hemodynamic monitoring, SpO2 should be okay, heart rate should be okay, blood pressure should be okay, should be able to void urine, should be able to take water, and ultimately should meet the discharge criteria. Now, this is just an example of PACU discharge criteria, but you can have your own criteria, you can have your modified criteria and see what best works for you. But before the child goes, the child should be awake, active, should be able to ambulate, should be able to drink and eat, and should not have pain, nausea, vomiting, should not be bleeding from the surgical site. That's how we say. And then should not have emergence. That's when we say that the child is fit to go home. Now here, things are not as simple as we see. There can be troubleshooting. If there is inadequate analgesia, the child is in pain, it will result in readmission. You've given a caudal block and there is urinary retention, there could be a delay or a readmission. If the child, you've added probably clonidine or dexmedetomidine to your caudal, or you've given some opioid, the child could be sleeping too much in the PACU and you can't discharge. So there's a delay. The child may be vomiting and it may or may not delay or readmission, but it'll certainly have a poor overall satisfaction, especially by the parents. Emergence, we've already talked about. Now, any respiratory complications, surgical complications will definitely cause a delay or a readmission as a full-time admission. So this chart, I took it from an article, which is the same thing as we talked about, but they've, very systematically, they have put as component of process and outcome measure. So suppose the booking process, there was a problem in the booking process. The outcome measure was patients failing to attend for surgery. You booked a case for daycare, but the patients haven't reported in time. Pre-op preparation, again, the patients have cancelled or they have come late. So the pre-op prep couldn't be done. Admission process. Now that affects the theatre start times. So if there is a delay in the documentation or anything in the admission process, the scheduled time in the OT gets disrupted. Now, quality of anesthesia also. Any lapse in the quality, there would be a delay or an unplanned admission. Same for recovery, same for discharge process. Now, there would be unplanned if the discharge process has not been robust, the parents of the child are going to keep calling the hospital, and that's going to be a problem for everyone. Now, post-op follow-ups that I was talking about initially. Now, if there is a lapse in that, if somebody from the team has not called up and found out, there can be a problem. Then the parents would start calling for repeatedly, and there could be a disruption in your process. Now, audits. I'll come to it here. So overall daycare, if I have to make it effective and safe, it's very important that we have regular clinical audits. We have processes that lead to quality improvement. We have a lot of teaching and training, because the whole team, not just the anesthetists, the surgeons, your technicians, nurses, the admin staff, they all need to be tuned into this process of daycare, because if it's a chain. Now, any weak link in the chain could be the problem. So in the West, they have dedicated daycare units. So everyone is trained in that system. Everyone is trained. And that's how it runs very smoothly. So and this is a continuous process. It's dynamic, that you keep teaching and training and improving, and repeat. And then the strength in following up the patients. The child has gone home. Everything was perfect through the day, and the child's gone home, but not been followed up. So that could lead to a lot of problems. So follow up, whether it's telephonic or somebody goes and checks up, it's extremely important. And one more thing which I haven't talked about earlier is, when you send the child home, in fact, when you book the patient for daycare, you should see where is their house, and what kind of emergency healthcare facility is nearby. Because if there is a problem, are they very far from your hospital, or somebody close by can attend to them? So that part is also your responsibility as a team, of course. So we must take. So the whole idea is to make more and more cases daycare, to decrease the cost, increase the efficiency, increase the satisfaction, and yet keep it safe. I think in our country, we will reach there. And with a lot of efforts and what we are having right now, the teaching and training part, we will get there soon. And I hope this talk at least stimulated all of you to go more pro towards daycare, even if it's a child in your care. Thank you for a patient hearing, and I would love to take questions after the talk. Thank you so much.
Thank you very much, Dr. GOYAL. So it's a very wonderful presentation with a lot of information. So there is no questions in the chat box. So I think you are in out of country. You joined.
Yes, good morning, everyone. I'm at Istanbul right now, but I'm very happy to see you all, and I'm glad I could record and give you the talk. But if there are any questions, any comments, I will be very happy to
thought you
share
are out
them.
of country, and I didn't encourage the questions for the discussion. But anyway,
No worries. People can still ask, or we can have an interaction if anybody wants.
Yes, madam. So, in your experience, you go for only the procedurals anesthesia, or you will go for interventional anesthesia also for the daycare?
No, it's not like, you mean only procedural sedation is to be considered? No. So it's beyond that. It's beyond that. It's not just parenteral sedation for daycare. We do a lot of surgeries which are daycare, because thankfully now most of our drugs are very short acting, and we can go low on opioids, and in a lot of cases we don't have to give opioids if we are thinking of daycare. We have NSAIDs, we have very good paracetamol, we can have local infiltration, some short acting regional block. So it's not just sedation, it's proper GA. Proper GA also can go home, and they routinely do.
Do you practice caudal anesthesia for later surgeries?
We usually don't. We don't, unless the case was done in the morning and we have a good couple of hours. If I'm doing a caudal, then I don't add any drug to it. It's just local anesthetic. And ropivacaine is pretty good. We don't have urinary retention. So it's not a clear-cut yes and a no answer. But yes, you should see. If I'm doing a case in the afternoon, I would probably not give a caudal with an additive.
Can we go for any other nerve blocks for the post-operative anesthesia before discharging patients?
Yes. A single shot nerve block never hurts. It's all under GA, and we should give, because after all, you don't want the child to go home and cry and the parents giving you a call, and nothing much you can do. There's no IV access at home, and in India we don't have a system to send a nurse home to give anything. So like in other countries, they have a follow-up by the nurse. After the daycare, the nurse calls up, looks up the patient, advises. We don't yet have a system like that. So we call up and we give a duty number so that the parents can call us up and let us know.
So you are following the tele-follow for the patients?
Yes, daycares who go home, they definitely need to be followed on the phone. We can't just leave them on their own because anything going wrong, we'll be responsible, and we don't want that. And we don't want any trouble with the patient either. When you're doing a kid, you want the kid to be very good. You don't want the kid to have any troubles at home. So a lot of counseling, a lot of time goes in counseling. We counsel, the surgeon counsels, we counsel again, then in pre-op, in post-op, and finally when they are going home, we reinforce the same counseling. And we have made a PDF document so that the surgeon and us, we talk the same language. Now, if I say you can have, a meal after 2 hours, and the surgeon says no after 6 hours, the parents will be all confused. What do I do at home? So we talk the same language. After every single case, we decide, okay, what are we going to tell the parents? And usually we counsel together. We go together and counsel. And I think that's made a lot of difference to work as a team when you counsel the post-op together. So surgical bed, they say.
Patients, you need to educate patients.
I think this is very basic, so long as you can connect to a patient from a rural area also. It's all about connecting with the mother or the father. So I think they all understand when it comes to their children, safety is what every parent understands. And we don't use technical terms either ways. We tell in very simple terms that the parent can understand. It's just you need a little more time and patience for that. That's all.
Definitely, madam. Dr. Surprasad sir, any questions, sir? Dr.
Ma'am, no, sir. It was a very nice presentation. My experience with daycare and pediatrics is so low. I don't have much to ask. But it was a very nice, enlightening presentation. Probably when I get my case next time, I'll be very easily going through these cases. Thank you, ma'am.
Thank you so much. Thank you. And I want to tell you that all infants for short procedures, please let them breastfeed in your recovery room. It's magical. They they don't consume much milk, but it's so kind of calming, and it also has analgesic effect. So they're like, you don't have to give too much of analgesia. So all infants or around that age who are on breastfeed, we insist that the mother feeds them in the post-op room. And nobody vomits. If you've not done a laparotomy, you've not touched the gut, they don't vomit.
Yes, most of the anesthesiologists, we prefer daycare surgery for the adult. So for the pediatrics, we have to learn a lot. Thank you so much, madam, for your wonderful
Thank you so
presentation.
much. I enjoyed. So yes, thank you so much.
The difficulty in daycare surgery in pediatrics, you highlighted very nicely. Thank you very much, madam. Thank you, Dr. Dinesh, Dr. Goyal, for a wonderful presentation of this week. So we will come to the end of this session today. Next week, we are having interesting topic of fetal emergencies by Dr. Anji Gupta and that is fetal surgeries by Rajalakshmi Madam from AIMS. We will meet next week. Thank you. Once again, I wish you all a happy World Anesthesia Day. Thank you. Thank you. Thank you, Joseph Prasad sir. Thank you, A1 Logics.
Thank you, sir.
Anesthesia TV and Akaruna. Thank you.